Hi, all, and thank you so much for your patience as we get started here. We are ready to rock. Hello, and welcome to One State's winning strategy to improve care for dual eligible individuals. Today's exciting webinar is sponsored by Conduent and produced by SmartBrief. My name is Jess Steinbach. I'm with SmartBrief by Future B2B, and I'm so happy that I get to be here with all of you for this conversation today because we are going to get into some exciting things. We're going to unpack and explore dual special needs plans, the changing landscape, trends, and what you need to know to get proactive, to plan ahead and prepare your organization as we head into this new year. I know, I can't believe we are already bringing 2024 to a close. How did that happen so quickly? Now, I know that as we go through our session today, you are going to have a lot of questions, and we absolutely want to hear from you as we go. So we're going to start out our day here together with a quick tour of your audience console to make sure you know where everything is so you can get involved as we go through our conversation. So let's start out. We're going to find the questions tab. If you haven't already done so, give us a hi, give us a hello, give a little wave to the community out there with us. Tell us what you're going as for Halloween if you're dressing up tomorrow. I'm very excited about that. As a quick side note, that questions window is also going to be the best place to reach out and let us know if you're having any technical issues as we go through our session. Hopefully that doesn't come up. I feel like we've gotten all the gremlins out of our system right away. We're done. We're good. But if any gremlins have got a hold of you today, no worries. The first thing you're going to try is a browser refresh. So give yourself a little browser refresh. If that doesn't work, shoot us a message right there in that questions window, and our team will be there to help you out. All right, so we started in the questions window. We're going to go one tab over to the handouts tab because it is absolutely full of cool resources and follow-ups to our conversation today. And this is just going to be the start. We have so much to dig into and so much to get through, and you are going to want to read more. So make sure you spend some time in that handouts tab, get those resources before you head out today. All right, the very last thing that I want to tell you about before we get started, I know that some of you saw that little prize icon and your eyes just lit up, and I get it. It's very exciting. We do have a $250 Amazon gift card that we will be giving away at the end of our webinar. Now, you do need to be here live and present at the webinar in order to win that gift card, and all of our winners must meet the SmartBrief prize terms and conditions. If you're not sure what they are, if you head back on over to that handouts tab that we were just chatting about, you can find the full T's and C's waiting for you there. All right, well, with that, I think it's about time that we get started because as you can see from our slide here, we have a lot to cover, a lot of exciting things to get through, and I am very happy to introduce you all to today's incredible moderator, and that is Shelly Forensic. Shelly is the Healthcare Solutions Leader at Conduent, where she oversees the strategic direction, product development, and client service teams, big teams, important teams. Prior to Conduent, Shelly has extensive experience working with health plans, holding various senior positions at Aetna and United Healthcare. So lots of experience there, lots we can learn from you, Shelly. So excited to hand things over to you today. Thanks for being here with us.
Thank you, Jess, and apologize to everyone for the delayed start. We had technical difficulties, and actually one of the panelists commented that this is why they will never own an automated car. And we all agreed. So I just want to start by thanking everyone for attending today's webinar. We're really excited for this opportunity. We pulled together some industry experts. We've been working together on this, and we want to discuss a topic that is near and dear to all of our hearts, which is dual special needs plan members. We have a very informative session today, so let's just go ahead and get started, and I will go to the next slide. All right. So let's meet today's panelists. So our panel today starts with Kirsten Lausch. She's the Managing Director of ATI's Managed Care Strategy and Operations Practice. She spent her career working with health plans, states, and community partners on issues related to Medicaid and Medicare, delivery systems, and health-related social needs. Also joining us is Anastasia Dodson. As California's Deputy Director for the Office of Medicare Innovation and Integration, her office provides focused leadership for Medicare topics in the state, including both dual eligible and Medicare-only beneficiaries. She's been on the department's healthcare leadership team since 2013. And finally, Sherry Katz. She is the program manager for Central California Alliance for Health. And in her role, she manages the strategic planning, implementation, and evaluation of Medicare Advantage D-SNP programs. Sherry and her team are dedicated to delivering streamlined care coordination and improving health outcomes for dual eligible beneficiaries in the Central Valley. Thank you so much for joining us, Kirsten, Anastasia, and Sherry. So we are going to start by bringing Kirsten in to kick us off and help us get a better understanding of the broader D-SNP landscape, market trends, and status of integration between Medicare and Medicaid. But before she gets started, we'd like to start with a poll to get a sense from the audience on how you view your state's integration status for dual eligibles. Is it coming up? No, it did not come up. Okay. I will just, there we go.
Yep, we got it. We're with you.
Okay.
There's our poll.
All right, there we go. So go ahead and with your polling capabilities, and I'll just start with asking Kirsten, how do you think this is going to come out? Don't look at the results yet, but how do you think this poll is going to come out, Kirsten?
I'm feeling maybe I'm going to go sit partially integrated is maybe kind of where folks are at.
All right, I think we've got results here. And are those showing? Jess, are the results showing now?
We're just going to click one more.
Okay.
Are you ready? Drum roll. There we go. There we are.
So what do you think, Kirsten?
Yeah, I mean, there's so much movement that has been made in the market over the last couple of years and momentum going into 2025. So this definitely feels like a lot of folks have been working hard to really make sure beneficiaries get a strong experience. And so this definitely feels pretty accurate.
All right, great. So I'll turn it over to you to go into your piece of the presentation. Thank you very much.
Well, thank you so much for having me. I think just a real quick information here about ATI, kind of who we are. You can see here on the next slide. We really dive into a variety of areas. When it comes to, as an organization, we provide advisory services, research. We have some amazing data capabilities in our team that have allowed us to really dive into the D-SNP space with that kind of foundation around policy. And so wanted to share a little bit today, kind of talking through what we are seeing across the market, and also kind of, set up a little bit of context for the great information and learnings that we're going to be hearing from our colleagues in California. I think so first, starting here, I think it's always valuable and important to really start to think about, first, what, let's take a moment and think about really the individuals whose healthcare coverage, care experience that we'll actually be talking about today. So we know that dual eligible individuals are those who are dually eligible for both Medicare and Medicaid. And this really requires them to navigate a fragmented delivery system across those two programs to access needed services. Those kind of span across healthcare, behavioral health, long-term services and supports, social services. And through kind of looking at the data, we are really able to see, this kind of very, probably no surprise to folks joining us today who've been working in this space, but dual eligible individuals often incur some of the highest healthcare costs due to high rates of medical, social, and functional need. And care delivered to dual eligible individuals account for 27% of Medicaid spending, even though they really only make up 13% of Medicaid enrollees as a whole. And we see that same kind of comparison in Medicare, where spending accounts for 35%, but the population accounts for 19% within the, across the spectrum of traditional Medicare enrollees. So I think just kind of keeping these pieces in mind as we talk through some of the elements that we're seeing here today. And so diving in now more into some of the policy pieces and content, really being able to kind of, I think, set a bit of a picture here of what we're seeing as far as kind of where our kind of dual eligible beneficiaries really being served. And so you can see kind of it across the board in both Medicare and Medicaid. So very different landscapes. So in Medicare, they may access their benefits through fee-for-service or through Medicare Advantage, which could be a traditional Medicare Advantage plan. It could be a C-SNP or a chronic condition special needs plan. This is for people who are living with a severe or disabling chronic condition. Or it could be an I-SNP for people who are, it's institutional special needs plan for people who live in a skilled nursing facility. Then you also have D-SNP, which we'll be chatting about here today, which is our plans that are designed specifically for individuals who are dually eligible. In addition to that, we have a pilot that CMS was able to kind of dive in and look at this experience of bringing together Medicare and Medicaid through the Medicaid program. That we'll talk more about this on the next slide, but it's, you know, that is coming to an end here after 2025. And so many states and CMS are looking at opportunities to really strengthen that experience in the D-SNP. And I think very similarly on the Medicaid side, you have some folks who are being served in Medicaid through fee-for-service, while others are being served through various managed care arrangements. All right. So as I mentioned, we had a model that CMS really kind of helped to spearhead in partnership with a handful of states that established really a three-way single contract for both Medicare and Medicaid services. And that program is sunsetting after 2025. So in 2026, many states are kind of kicking off that we're participating in this MMP program, looking at different opportunities to really strengthen the experience for their dual beneficiaries moving into kind of a D-SNP model. And so we see this with states like Ohio, for example. And then when we look at D-SNPs and really trying to understand, you know, what are the elements of a D-SNP, you have, I think, first and foremost, they have to have a state Medicaid agency contract, a SMAC, with the state that they are operating in, which includes kind of those core federally mandated elements, as well as additional contractual requirements that a state might include based on some of their goals that they have around integration. And we'll talk a little bit more about kind of how some states are showing up in that space and what that looks like of how they're leveraging the SMAC. And then D-SNPs also have to have, you know, at minimum, coordinate Medicaid services. But you can see here in the different types of D-SNPs, really, you know, some also cover Medicaid services such as long-term care services, behavioral health. And then lastly, be able to cover kind of the full suite of Medicare services, and then also have an approved model of care specific to dual individuals that address the various elements requirements. So really kind of important piece. When we look at, as far as kind of the types of D-SNPs, you have the coordination only D-SNPs, which really, you know, they do not bear Medicaid risk for behavioral health or long-term services and support in the same service area, but, you know, they really are expected to coordinate. That looks like sharing data, collaboration, and a lot of states are leveraging how they partner with coordination only D-SNPs to support alignment between Medicare and Medicaid. Then you have high D-SNPs, those highly integrated, which they either bear Medicaid risk for behavioral health or long-term services and supports in the same service area. And then lastly, the FIDE SNP. So they're bearing risk for both behavioral health and LTSS. And so just kind of a little bit of recap of when we talk about D-SNP, what are we talking about? So diving into just some of the market trends that we've seen, and I know the slides will be shared so folks will be able to kind of sit with these a little bit more, but we have seen kind of dual eligible enrollment in Medicare Advantage really grow. And you can see across the board, individuals who are receiving kind of those full Medicaid benefits, partial, and, you know, non-dual growth within Medicare Advantage has certainly grown, but you're seeing much more significant growth in those kind of amongst the dual eligible population. And we see here that certainly, you know, when you look at where dual eligibles are enrolled, as we talked about kind of on that first slide of mapping out where folks could be receiving their benefits, dual eligible individuals can really enroll in any of those types of Medicare Advantage plans. But we do see, as we look at the data, that individuals who are dually eligible are, you know, primarily moving into D-SNPs. And then this, just to kind of, I found this one really interesting when we talk about where individuals are moving. So when we have the chance to kind of look at, okay, you know, where was someone in 2023 and where did they move, kind of switch plans to in 2024? And when you look at this, we see that, you know, the majority of dual eligible individuals that made a switch to a different type of Medicare plan type in 2024, they moved largely into SNPs, into D-SNPs, as well as into traditional Medicare products as well, so those non-SNPs. So we're, you know, seeing more movement from fee-for-service into Medicare Advantage, but duals having a significant presence in those D-SNP products. And kind of switching gears, so, you know, this has been a little bit of retrospective. So now being able to kind of look at what are we seeing already for 2025. We can see here that really continued growth in the average number of Medicare Advantage plans that are being offered in 2025. You see that growth, you know, in MA plans overall, but particularly in those D-SNP plans. And again, here kind of another different look at it of kind of what are those total numbers. You can see we've got a significant number, more so of D-SNPs than you see with I-SNPs or C-SNPs in 2025. Now, when we kind of take a step back and look at, okay, what are D-SNPs actually, you know, how are they looking at tailoring their experience and services and supports for these individuals? One area is really looking at supplemental benefits. And as we looked at what was being offered in 2025, you can see some significant growth and offerings, particularly in food and produce, non-medical transportation, and kind of those general supports for living. So think of kind of utility support, for example. And you can see across the board that SNP plans are certainly increasing the offerings there in their supplemental benefits, but really very much so in the D-SNP space to meet those members' benefits. All right. And then moving into kind of what we're seeing across the states and some of the pieces as far as integration, I think folks have, I'm guessing who are on this call, have been paying close attention to the work that CMS has been doing to really support and drive alignment. And so there has been kind of building blocks going on here over the last few years of changes in the annual Medicare Advantage Part D rule, which we expect to drop again soon. So we may be seeing some additional changes coming for this calendar year, and that will further evolve the future-facing experience for dual eligible individuals. So I won't go into detail on this one. I think just to kind of provide a snapshot for folks as you're kind of looking back of what are all the pieces that we're seeing come together. But really just to kind of take a quick focus dive in on this next slide, some of those particular elements. So I think as we're looking at this one, a lot of folks are looking at mile markers around 2025, 2027, and 2030. So in 2025 for D-SNPs, we're seeing a few different policy changes. In 2025, that looks as full benefit dual eligible individuals will be able to use a new monthly special enrollment period to enroll in an integrated D-SNP if it results in aligned enrollment. So having the same parent organization delivering your Medicaid and Medicare benefits. In 2027, we see that, continued evolving where new enrollment into D-SNPs with an affiliated kind of Medicaid MCO in the same service area must be aligned for Medicare and Medicaid. And then in 2030, D-SNPs must disenroll any legacy members for whom, they don't also have Medicaid risk through an MCO. And so there's certainly a lot of evolution occurring here that folks are really working towards that enhanced integration. And I know I mentioned, when we were talking about what makes up, kind of the elements, requirements of a D-SNP, just flagging how states are, really looking at how they use that SMAC to be able to shape and influence how dual D-SNP products are being delivered in their market to their residents of their state. And you can see here a few different examples of how states have started to engage in that SNP process. Some have gone ahead and limited the number of D-SNP plans to MLTSS plans, and so have really kind of looked at it as a separate kind of contracting process of only offering SMACs to those individuals who are, kind of taking on that risk in the LTSS space, influencing supplemental benefits, informing and influencing the model of care. So really helping to shape what that experience looks like, kind of top to bottom, both of like the program design as well as the benefit design and other program elements. And then just a quick map here looking at what we're kind of seeing here in 2025. You're definitely seeing kind of continued growth of states that have, new HIDE experiences, have a kind of even new to D-SNP in general for North Dakota, but you can definitely see this map looks a little bit different and kind of moving towards more of that red, pink, gray year over year as more states look at opportunities to really leverage. So I think just kind of an item to flag here of what we're seeing across the market. And last, I think just kind of to flag and walk through here, just where we're actually seeing states kind of what strategies they're really taking. You see, as I mentioned, some states that are really focusing specifically on exclusively aligned enrollment, focusing on that FINESNP model in 2025. And we have 12 states that have pursued that approach, Hawaii being one, where they really looked at kind of their Medicaid contract and have limited that FINESNP participation into those that they're contracting as a whole with their Medicaid program. And they've seen a significant increase in alignment there of dual eligible individuals moving into those FINESNPs. And then also Massachusetts, which really kind of contracts those programs out separately. Then you also have states that are taking kind of a capitated approach of carving in Medicaid services into the SMAC. So Florida, for example, has taken this approach that has been in place for several years. Other items around kind of default enrollment, so where individuals are automatically being enrolled into an aligned product. So on the kind of Medicaid side, most often is where that enrollment is taking place. So if you selected a D-SNP product, automatically being enrolled into the aligned Medicaid product for that parent company. And then same with items around RFP requirements, of how, really being able to stand up these products, and then also looking at how auto assignment algorithms function. So there's a lot here, and so I'm going to go ahead and turn it over to our colleagues from California.
All right. Thank you, Kirsten, for your insights on the D-SNP landscape and the trends that are happening in this space. It's a great segue into Anastasia's overview of the innovative strategies and tactics that the state of California is employing to integrate care for D-SNP. So I will turn it over to Anastasia.
Hi there. Thanks so much. Very glad to be here. I'm Anastasia Dodson at the California Department of Healthcare Services. So I'll go quickly through these initial slides. You may be probably familiar with this. Of course, people with Medicare and Medi-Cal are more likely to report being in poor health. They have higher rates of chronic conditions. And in California, they're an especially diverse group. About 25% of duals are under the age of 65. 33% have limited English proficiency. And then just as an example, about 18% have dementia. So they're also high utilizers of our long-term services and supports, particularly our IHSS personal care services program and skilled nursing facilities. So, oops, it looks like it. Great. Okay, about 1.7 million Californians have Medicare and Medi-Cal or dually eligible. About half are in original fee-for-service Medicare and half are in some type of Medicare Advantage plan. Our Medi plans, that's the name of the D-SNPs that meet the definition of applicable integrated plans. We have around 300,000 members in 12 plans. And just by the way, those are the successors to the financial alignment demonstration plans that are winding down in other states. We also have a FIDE-SNP with about 20,000 members and then about 20,000 members in PACE organizations. So that's where they are on the Medicare side. On the Medicaid side, which in California is Medi-Cal, all dual eligible beneficiaries are enrolled in Medi-Cal managed care plans. But as I said, only some are enrolled in Medicare Advantage, and then of those, some are in D-SNPs or the FIDE-SNP. All right. So Medi plans, those are, again, our applicable integrated plans. They are a combination of a D-SNP contract that we have with the D-SNP, and of course CMS has with the D-SNP, and then the Medi-Cal managed care plan that is aligned with the same organization that offers the D-SNP. And combined together, we call that a Medi plan. It's presented to the members as one plan. But as you all know, on the technical side, again, there's two separate contracts, and the D-SNP provides the Medicare services, and the Medi-Cal plan provides the wraparound like cost sharing, long-term services and supports, and transportation. So again, the Medi plan is a generic term that we use in California for these applicable integrated plans. Each D-SNP, of course, uses their own marketing name and plan-specific materials, but from the member perspective, they're described as a single plan, and the members get one card, one welcome packet, and have one phone number to call for member services. That's very important. That is the whole point of integrated care. We do have many fact sheets and a list of the Medi plans by county that are posted on our website. This map gives you an idea of where we're at right now. So the orange counties, we have 58 counties in California. The orange counties are those where the Medi plans are currently available in 2024 and in 2025. The dark blue is where the Medi plans will be newly available starting in 2026. And the lighter blue in the rural areas and the northeastern part of the state, the plans will be phased in those counties sometime after 2026. But I should say that those orange counties, which include Los Angeles, San Diego, San Bernardino, Riverside counties, include a large population, and then plus areas of the Central Valley, including Sacramento and Fresno and parts of the Bay Area. So already we have these Medi plans are available to a large number of dual eligibles in the state. Okay, so this is just another way of care coordination, of course, is a central requirement of all D-SNPs, and applicable integrated plans like the Medi plans have a very strong responsibility to coordinate care for their members across all Medicare and Medi-Cal benefits. We do have some benefits that are Medicaid benefits that are carved out of Medicaid managed care in California, but those Medi plans are still responsible for coordinating those benefits, such as dental and personal care services. But many of the benefits are carved in, like durable medical equipment, adult day health care, so transportation. So anyway, that whole array of benefits needs to be coordinated by the D-SNP, by the Medi plan. And again, we talked about on the last slide a little bit about the carved out benefits. Personal care services, known as IHSS, are a significant benefit in California used by dual eligibles. County behavioral health is not part of our Medicaid managed care plans, and dental. And again, those Medi plans need to coordinate those benefits as well. And one thing we try to emphasize is that joining a Medi plan does not impact a member's IHSS benefits. That's very important to members in California. We try to also emphasize to folks that are just learning about Medi plans that it's the Medicare network that is really the dominant provider network, but of course members also have access to the Medi-Cal provider network through their plan. And we emphasize, again, because networks are so important, that if someone is new to the plan and if they find that their provider is not in the network, we want that Medi plan to work with that member's providers so that they can be added to the network, or of course the plan will help them find another physician. And there's a continuity of care period where we want to promote continuity for those members to join the plan and have the provider and the health plan work together on an agreement. And how to join a Medi plan? Of course, people need to have Part A and Part B to join any type of Medicare Advantage, including these Medi plans. And they have to have Medi-Cal. They have to be age 21 years or older. They have to live in one of the counties where those plans are offered. Enrollment in Medi plans is voluntary, and they can contact their plan or 1-800-Medicare. So the last couple of slides I think are important to, these may be questions that folks in other states or elsewhere may have questions about. So we did have a financial alignment demonstration that was known as CalMedi Connect, and those there were 7 counties with health plans that participated. That transitioned to these Medi plans or AIPD SNPs January 2023. We had a very smooth transition of about 113,000 members. And as you may recall from the earlier slide, we now have over 300,000 members in these plans. So we've seen good growth, but we did have a very good transition thanks to close coordination across the plans, the state, CMS, advocates, plus a lot of wonderful TA from CMS and the Integrated Care Resource Center, and a lot of stakeholder engagement. It was a significant planning and communication effort. We had a lot of meetings, pivoting as needed. We had regular public meetings, and we had fact sheets and videos. We tried to communicate often and in many forums. We shared draft policy documents. We took feedback. We published and discussed enrollment and demographic data. And if anything that didn't go as planned, we tried to be very transparent about that. And we did consider and clarify concurrent issues. So there was a D-SNP lookalike transition also occurring around the same time. So we tried to be very clear about that. The other thing that we have done is taken up the option from CMS to require a D-SNP only H contract. So this option allows us to get HEDIS measures that are specific to California D-SNPs. Otherwise, there could be multiple states and MA plans members as well in HEDIS measures. So that's been a good step for us and will help us look at things more specific to that population in California. We did expand 3 existing Medi plans to 5 additional counties in 2024. So that was good to do a more gradual expansion before the bigger expansion that we expect in 2026. So we are right now very deep in working with those additional Medicaid managed care plans that are going to launch new D-SNPs in 25 additional counties for 2026. So that's our big effort right now. We've also made some policy decisions. So existing D-SNPs that do not have aligned Medi-Cal plans are closed to new enrollment in 2025 and ongoing, although we do allow current members to remain enrolled. And we are only approving new D-SNPs if the plan is aligned with a Medicaid managed care plan in California. So we're hearing about, there's too many D-SNPs, too many choices. So we're trying to just make sure that we have those fully integrated plans, not technically FIDE SNPs, but plans that are also capitated for the Medi-Cal benefits so that they have all the aligned incentives there. In future efforts, we'll continue to monitor the plans and improve the monitoring and reporting. We're updating our care coordination policy, and we're looking at ways that we can improve coordination for dental, behavioral health for members experiencing homelessness, palliative care, and looking at the redeterminations in our deeming policy. All right. So it looks like that's the end of my slides, and I'll hand it back.
All right. Thank you, Anastasia, for sharing how California is staying ahead of the curve in advancing health equity by better serving the needs of the D-SNP population in California. Health plans also play an integral role in advancing D-SNP programs. You heard Anastasia say how coordination is key. Our next panelist is Sherry Katz from Central California Health Alliance for Health, and she's going to give us some insights from a health plan perspective. But before we get started, we've got a poll going to see what you believe is the biggest challenge in implementing integrated D-SNP plans. So let's show that result. And it is resources. So Sherry, I think you're going to shed some insight on this, and I don't know whether you agree with that or not, but love to hear from you now, and I will turn it over to you.
Great. Thank you so much, Shelley, and thank you for having me today. I am not going to disagree with the results here. I think probably depending on the plan and where the plan is located, you could probably go any of those three ways. I do have some insights that I just want to share with the group. Being the program manager for the Central California Alliance for Health, we began implementing a D-SNP program. We are a COES plan, so we are a county organized health system. We really are the only Medi-Cal plan in town with roughly almost 500,000 Medi-Cal lives. So really the organization didn't have any Medicare experience. We're really coming from a place of Medi-Cal. And so one of the things that we wanted to share with the organization early on was, what's the roadmap look like for us to get there? This is the big picture. So we know that there was a requirement under CalAIM, but what are the tools and resources that we're going to use to get to the finish line, which is January 1st, 2026. So go ahead, next slide, please. So we thought we needed to provide the organization with some building blocks. And one of those building blocks is really to make the work an organizational priority. Medicare cannot be built off the side of the desk. So if you're really focusing on the Medi-Cal line of business and you're kind of just spending a little bit of time on developing your D-SNP program, you're probably not going to be successful. It's really important to start early. So I'm just going to mention that. D-SNP requirements are incredibly important. We really need to assess what is it that you're doing today and what are those gaps. Identify and document those gaps, and you're going to continue to refine that, because as you move closer to the implementation phase, you're going to find that you have additional gaps. The other thing is you need to identify dedicated functional leads to take the lead in managing the work. The work doesn't happen in a silo. It doesn't happen in a specific functional area. It happens across the organization. So one of the things that we really advocate for is this cross-functional work groups. Everyone needs to know what everyone else is doing, and nothing happens in a vacuum. So those cross-functional work groups can be incredibly important just to make sure that everyone is aligned with goals and timelines. As you know, CMS and DHCS have pretty strict deadlines of when things need to be done. So we want to make sure that everyone is meeting those goals and driving towards sort of those deadlines. Hiring. I think early on, we didn't think we needed to hire as many people. We're finding out that we need to do that. education and training is critical. Documentation and organization of kind of what it is that you're doing in the roadmap becomes important. You don't want to just educate and train without documenting what it is you're educating and training on. We've also found that communication, it becomes incredibly important. If you're not communicating early and often, you're missing the boat. And then also deadlines. Like I mentioned before, there are a tremendous amount of deadlines in this regulatory space, and we just want to make sure that we're not missing any of those. So those are kind of the keeping the eye on the ball. Go ahead, next slide. So again, raising awareness early throughout the organization regarding what the goals of the CalAIM initiative are, understanding what regulatory regulatory implications of the D-SNP, and how the program really is integrated with Medi-Cal. This is not a standalone program that happens by itself. It absolutely is integrated with the Medi-Cal line of business. And so as you're standing it up, we really need to make sure that that integration is happening and it's solid. We also want to make sure that we're guiding and advising as needed those functional areas on the operational staffing and any regulatory gaps, knowledge gaps, and each of those functional areas need to work to cure any identified gaps that are identified. Cross-functional work groups, like I mentioned before, incredibly important. We need to make sure we have documented work plans with specific and prescriptive deadlines to ensure that the needs are identified and then we're meeting them by those established timelines. And I can't say this enough, but training. Medicare is a different animal than Medi-Cal, even though they sound similar, they're not. How they work together is also complicated. And so we wanted to make sure that we're designing and deploying different levels of training for the organization. So from the basics up to very complicated and functional types of training programs. So next slide. This is just a wheel to kind of show all the different moving parts that are identified within a D-SNP, and a lot of them are new to the organization. The Medi-Cal didn't really have to worry about a pharmacy benefit, a formulary, because that was done on the Medi-Cal side with Medi-Cal RX. The network is different. We didn't have a marketing team or a sales team. We didn't have to worry about developing a particular product with an actuarial partner. So there's a lot of new functions within the organization that we need to introduce and get people comfortable with. The next slide. So we adopted guiding principles. We wanted to make sure that as we moved through the development and implementation phase of our D-SNP, these are things that are grounded in how we operate on a day-to-day basis. So one of the things that we said was we cannot break Medi-Cal. So our existing lines of business, our Medi-Cal and IHSS, those have to remain untouched. So whatever we do to stand up this D-SNP, we can't break our existing lines of business. And how do we do that? So this is really the rails on which we are running this particular project. We understand that any significant changes to these principles could impact negatively cost, scope, timeline. And so we make sure that our executive sponsor is engaged at every level to make sure that we are operating and proceeding consistent with the documented work plans that we have. So again, we're saying that we're going to be able to accept enrollment on 10/15/2025. That is one of our guiding principles. All decisions that are related to this particular project have to be, cannot disrupt our providers or our members that exist today. We have sufficient time that we're giving towards the implementation and planning for our readiness. System readiness is a very big identified, I'm just going to call it a bolus of work. We also want to make sure that we have dedicated team members and SMEs on the project. Constraints that are identified, those resource constraints, we need to identify those early so that if we need to hire staff or temps that we do that. And then again, I mentioned communication plan. Please have one developed from that's one of the very first things that needs to be done, because one of the things that happens within an organization is work starts to get done in silos. There's a lack of communication that goes out across the various parts of the organization, and sometimes people don't know what other people are doing. So having a solid communication plan and transformation team are critical, just also to manage, I think, the motivation and the morale of the organization given such a lift. Okay, next slide. Okay, so one of the things that I've always maintained is that there's kind of like the three-legged stool. There's money, there's time, and there's staff. And these resources are limited. We don't have unlimited money, we don't have unlimited time, and we don't have however many staff we would like to have. So really that sound implementation plan is critical to making sure that we know where each of these things is being spent. We know where money is being spent. We know where time is being spent, and we know where the staff is being utilized within the organization. Also, leadership support. If our leadership isn't supporting the work that's being done at the ground level related to this particular program launch, it's not going to grow legs and get off the ground. So it's incredibly important that the leadership from the very top is really articulating to the entire organization that this is organizational priority. And also that the organization is aligned. So all the staff and departments are aligned on where we all need to go and what we need to do to get there. From these three particular resources, I can tell you right now, believe it or not, it's time for me. We started this journey a couple of years ago to launch the D-SNP. Part of the challenge is people see a January 1st, 2026 timeline and they think they have time. Launching a D-SNP, regardless of where you are or what you've been doing before, is incredibly challenging. The organization needs some time to understand how a D-SNP works. So I would say time. If you can start early, get folks engaged and excited early, that will really be your best friend. We can always find more money, we can always hire more staff, but we can't get more time. So that is probably, for me, the most critical component and resource for the organization. Okay. Next slide. And then Shelley, I think this goes back to you.
Yes, you're right. And thank you so much for giving us that overview of health plans challenges and food for thought on implementing D-SNP plans.
Yeah.
I just want to share this slide before we go into the Q&A, which unfortunately I don't think we're going to have time for. We're running really tight on time due to our technical delays. This is a depiction of the health plan value chain as we see it at Conduent and our solutions that support it. So we provide all the solutions you see here and many others. And that's really so health plans can focus on the health of their members, especially this vulnerable D-SNP population we've been talking about today. I want to thank our presenters for an incredibly thorough and informative presentation and dialogue, and especially for adapting to our technical difficulties. And thanks to the audience too for your patience while we work through that. Just when you've thought of every possible test, one of them did not pass at the end. So thanks for your patience. We do have questions, but I don't believe we have time for those today.
We do. Let's do one question.
We've got
time.
All right,
yeah,
great.
We're going to go right up till the end of time. Let's do it.
All right, very good. All right, so let me start with one of them. And it is, what drove the phased approach to implementation in California? And I'm going to give that to Anastasia.
Sure, glad to respond. So the phased approach was based, of course, in the, I think it was 2011, 2012 timeframe when we were ramping up on the demonstration, financial alignment demonstration. It was clear that it would be a big lift for the plans. And so we had a process where we worked through to find, what plans would be ready and able to launch that demonstration over 10 years ago. So we knew that would be, of course, what we needed to do to transition those into the D-SNP model first. And again, we have 10 additional local Medicaid plans that do not yet have D-SNPs. So we know that these are, as you saw in the example, there's a lot of considerations that each plan has to work through and steps to take to launch the D-SNP. So it seemed like a very sort of appropriate approach to make a phased approach. And it's been successful in the launch in the Central Valley, for example, in 2024, so that we could focus on a smaller geographic area.
All right. Thank you. One more. I'll just do one more question. What are some key metrics for a successful D-SNP implementation? I think this is a Sherry question, but I think everyone could probably chime in on this one. So key metrics for successful implementation.
Key metrics. Oh, go ahead. Go ahead, Anastasia.
Yeah, I'll just say one of the key things that we looked at, again, with the 2023 and 2024 are the enrollment transactions working correctly. So number one is making sure enrollment works, and close number two, or a number one, is the provider network and making sure that people have access to providers, and that's working well. Care coordination pieces are important, but just the fundamentals, pharmacy, anyway.
Yeah, I would agree completely. And I would also say one of the things that's different in the D-SNP population is every single person gets an HRA within 90 days of enrollment, and that care plan that is developed as a result of that HRA has to be developed, is going to be unique for us from going from the Medi-Cal plan to the D-SNP. I think the network is probably one of the key things, and probably one of the hardest to develop because you're relying on providers within the area to want to enroll in your particular network or be part of your network. Oftentimes it comes down to negotiations. And so it's really a function of what the plan can afford. But yet at the same time, it's something that we absolutely have to have in order to meet the requirements. So for me, that's probably one of the more challenging areas of the development. And I think that's probably something, being in this industry for so long, network has always been a consistent challenge at every plan that I've worked at.
All great points. All right. So thank you again, everyone, for your participation in this webinar today. I hope you found it valuable. We all hope so. I certainly did. And so I'm going to turn it back over to Jess now to wrap up for us.
Yeah. All right. Well, one last goodbye and big thanks to all of our incredible speakers. Thank you so much for being here with us.
Thank you.
Right. Thank you.
Thank you.
And Shelley, I got to say, thank you so much for some great moderating. I know it's not easy, especially when things go off the rails, and you kept our show rolling and led us on a really interesting conversation. So a big thank you to you, Shelley.
Thank you.
All right, and to everyone out there that got some questions in, I know that we had to cut things a little short. So here's what we're going to do. We are going to send all of the questions that you asked over to the Conduent team and make sure you get some answers back. So if you had a burning question that we didn't get to, you're going to get an answer back. If you have a burning question that you haven't asked yet, you're holding on to it, now's the time. Make sure you get it into that questions window, because we are going to make sure that you get answers. Make sure you get those questions in. Now, here's another great way that you can get some information. If you visit the handouts tab right now, you can find these cool, they're kind of like postcards, little snapshots, focusing on solutions across the entire healthcare value change, unlocking operational agility. I love that. I think that's I love that combination, right? Operational agility is really important. You can also get in the ATI resources on programs serving dual eligible individuals. That's a great slide, great takeaway. That's like a nesting doll of takeaways. There's resources in that one, as well as an ATI advisory on how you can start to address the hardest problems in healthcare. Oof, that's a good one. That's an important one. Also, a really nice overview, a quick, easy read, about 2 pages on Conduent enhancing performance, experience, and value. How can you do more with less? I was geeking out a little bit about Sherry's comment on the one thing you can't get more of is time. Isn't that true? And boy, I wish we had more of it in our day. I wish we had more right now. I wish we had more time with all of you. But yes, so really doing more with less becomes more and more important in this world, right? And then there's a neat evaluation. It's a neat evaluation for Conduent, looking at healthcare payer operations transformation. So make sure you've got that as well. So lots of great takeaways, lots of things to spend some time with. Once you've wrapped up this webinar, make sure you keep those learnings going. Now, I know we're right at time, so you are saying to yourself, hey, Jess, what about our prize giveaway? And you're absolutely right. We have a $250 Amazon card going to a lucky special someone here at the webinar, and that is Amy Finelli from Pennsylvania. Amy Finelli Kelly from Pennsylvania. Congratulations to you. Now, as always, Amy, we will be in touch about claiming your prize after we wrap up the webinar. Well, it is unfortunately that time. As Sherry said, the one thing we don't have more of in our day is time. So we are going to bring things to a close. But on that note, I want to say a giant thank you to Conduit for being here. As I said, to Shelly for being an incredible moderator, to Sherry, to Kirsten, to Anastasia. Kirsten doing a great job of chiming in sans camera, and really appreciate everybody kind of rolling with that. We've gotten some really valuable expertise and actionable strategies, actionable steps that we can take in our organizations, as well as some great case studies and examples that we can learn from the real world. I mean, that is the best way to learn, right? Is seeing something in action that's working and then finding ways that you can make that work for you. So I do appreciate, in a day that is tight on time, that all of you have taken time out of your day to come and join us. So on behalf of the Smart Brief team, my biggest thank you is to all of you out in the audience for coming to join us, for being a part of this discussion today. And I hope that we'll get to see you all at a discussion, at a webinar again soon. And until then, have an absolutely beautiful end to your day. Thanks all.